Recorded at the Southwest Conference on Botanical Medicine in April of 2016. For more information on our conferences, lecture notes, and recordings, visit our website, botanicalmedicine.org.
So I'll just say a word about me if you don't know who I am. Jason Miller. I practice up in Ashland, Oregon. I've been practicing about 10 years through my clinic, Jade Mountain Medicine. I also spent about 6 years with Donnie practicing out of the Maduri Clinic. I was doing that part-time. I also worked for his company, Natura, for many years. I do a little medical educating for them now as well. If you were at Donnie's lecture yesterday, you have an inkling of an idea of what goes into the research end of botanical medicine from his mind. So I got basically that kind of fire hydrant effect for many years. So I think I'm permanently damaged. When I first was looking at doing this talk, I was thinking about talking about arrhythmias and all the different arrhythmias and seeing kind of how, let's just talk about all of them and see how they affect each other and what are the different types of arrhythmias, and spend a lot of time on all of them, like premature ventricular contractions, and talk about palpitations, because we in Chinese medicine in your training, we do a 4-year master's degree program, and you spend a lot of time talking about herbs and a lot of pathologies that involve palpitations. Patients are often complaining of what's this feeling in my heart? It's something I feel my heartbeat. Most of the time, we don't feel our heartbeat. Most of the time, we're just sitting there and our heart's just pounding away, taking good care of us, and we don't have to think about it, which is really one of those sweet gifts of life. But when you do think about it, and when it is a presence in your body, that's when we start to say, well, what's going on? So as I started digging deeper into this talk and studying atrial fibrillation, I realized just how big of a deal it is. AFib, I see it in practice all the time. People come in with AFib all the time, and it's a combination of drugs and different therapies that people are on, and people come in with lots of different pathologies, lots of different pictures, symptom pictures, including atrial fibrillation. But most of the time, if they come in with AFib, they've got a diagnosis. They've been diagnosed by ECG with AFib, and started digging around into this thing, and it's a big deal. It's a huge piece of healthcare right now, and I really want to just spend most of our time talking about that issue and that disease, maybe we'll call it for now, or that diagnosis at least. And we'll get deeper into understanding whether that is a disease or not, and how important it is to really define it as such. So let's do a quick review of the heart. And this is the simple heart. Here it is. In Chinese medicine, it's not so simple, but in this drawing, you can see, you basically have your sinoatrial node. I'm going to try your trick, David. Here I go. David, here it is. Oh, didn't work for me either. Does it work? There it is. Sinoatrial node. Look at that. This is the pacemaker of the heart. So basically, electrical activity enters the SA, the sinoatrial node, and then is distributed through nerve fibers down here to the atrial ventricular node, and then travels along these bundles, which lead to these Purkinje fibers, the bundles of His, and then the Purkinje fibers here, which then conduct the electrical activity into the myocardium, creating the heart rhythm and impulse, the contractility that sends the blood around our bodies. Of course, we've got a couple of nice valve structures here. You can see here we have the left ventricle, which sends blood out here through the aortic valve into the aorta to send blood out to the entire body. Here we have the right ventricle, which sends blood out through the pulmonic valve, out through the pulmonary trunk into the lungs, so that that blood will then get oxygenated, will return via the pulmonary veins here. These are important structures, the pulmonary veins. This is where blood comes back into the heart, and it's the only vein in the body that has blood that is oxygenated coming back into the heart, so that it can go into the left ventricle here through the, this is either the tricuspid, bicuspid, who knows? Anybody know? Well, it's the valve between the left atrium and ventricle that then is going to, the mitral valve, exactly. The mitral is a good way to go. Is it bicuspid or tricuspid? That's a good question. I think it's bicuspid. And then this sends blood out to the whole body that's already been oxygenated. So that's just the structure of the heart and just the mechanics, the simple mechanics of it. So as we go a little further, I just wanted to say something about the not-so-simple heart. because the heart is not just an isolated structure. It's neurologically and endocrinologically connected to a great number of structures in the human body that are all playing an integral part in influencing the heart. And in Chinese medicine, the heart is a central figure. They give a spirit to every organ, in addition to a physiological function. But each organ, like the liver, for example, carries a spirit called the hun in it, which is part of our dreaming self. It's sort of our astral self. And as the liver is our metabolizing organ, it's the general that kind of makes tons of decisions. It is the deciding and sort of like overview chess player of our whole endocrine system. It's influencing influencing the heart, as the emperor. The heart is existing as the emperor of our body. It's the fire element. It's the centerpiece. But it's constantly being given information from all of these other sources. So that's why I was saying there's a not-so-simple heart concept that's very important, because I think in cardiology we often find that we're looking at the heart as an isolated structure, and that can be problematic. But it can be really financially lucrative too. There's a lot of money to be made in that field. So this next slide is basically just a little bit of I don't want you to think about this and go, whoa, what is this thing? But this is just sort of a Chinese medicine diagram of some of the ways that the different elements interact, and you can see each one of these elements in this cycle of the 5 elements has organs associated with it. You can see at the top of each little circle, like here is the small intestine and the triple heater. This is the stomach, the earth, and here in the fire is the heart. And so all the things that influence the heart, the way that the bladder and the kidney influence the heart up through this, the generating cycle, the way it's influenced here through the shung cycle, this is the ke cycle. This is like an inhibiting cycle where water controls fire. And so there was a real elemental look at the body from traditional Chinese medicine. And a lot of traditional systems have that concept that we have an elemental or ecological look at the body rather than a physiological one. When this stuff was being thought up and designed, people were looking at the body from the outside. And they were looking at it in the context of a community and inside of a family and inside of a village. And over generations and generations, doctors recorded this data. And they would see, I'm the 19th generation doctor. So for 19 generations, my father's fathers treated your family's kids, mothers, grandfathers. And they learned a lot. And they put it into these incredible writings that they did. And there's more writing in that system than any other system in the world today. It's just, we don't have it translated, of course. It's all in Chinese. But what's amazing to me is that it's all derived before you dissected the body into its individual parts. So you haven't taken the body apart and examined every structure and tried to understand what that structure does. And to me, that's really cool. And it's fun when you can take that and really understand the body from that perspective and then overlay it on modern physiological understanding and a reductionist understanding of how the body works. And the two perspectives together give us something really special. So I'm a big advocate for understanding a traditional medical system like what David was talking about earlier and being able to come from a place of seeing the body as a whole. So, to the topic, arrhythmias, abnormal beats. I'll tell you right now, I'm a drummer. Abnormal beats are exciting to me, but they can also be really irritating to me too. So, a change in the normal sequence of the heart, the rhythm, and there's 2 main types of arrhythmias, the rate being too fast or too slow, or the rhythm itself being erratic. So how do we define arrhythmias? These are kind of some basic definitions. Atrial fibrillation, we're going to talk about at length. That's sort of the key topic here. Ventricular fibrillation obviously has to do with fibrillation of the ventricles. Bradycardia and tachycardia, slow and fast heartbeats. Conduction disorders, we saw in there the branches, the bundles of the nerves, when there are blocks in those bundles due to either drugs or chemicals, or it could even be emotional things, can be physical or organic changes. We lead to conduction disorders where conduction isn't happening in a well-sequenced and choreographed fashion. And then we have premature contractions, which are contractions that happen before something else, PVCs or PACs, right? Premature ventricular or premature atrial contractions. So we'll start with bradycardia. This is one you see in the clinic a lot. Of course, it's mostly with the elderly population. As we get older, our heart tends to slow, and people over 65 years of age generally are the ones who manifest bradycardia, although we'll also see it in athletes, and that's a very natural and normal occurrence to have a slower heart rate in athletes. But, it's not uncommon in the clinic that if you practice long enough that you'll see people that come in with a heart rate of 40 beats a minute, and they don't have any problems. They don't even know that they have that heartbeat. They feel normal. They might be a jogger, they might be a walker, maybe they're 68 years old, and then they get, you check their heart rate, and you're like, wow, your heart beats 40. And then that's really interesting. So then, this is something to consider, but in most cases, it's not a big pathological problem unless it is. And you'll know if it is because things will start to change. The person will not get enough oxygen to their tissues, and they'll suffer some kind of symptoms. And in the non-symptomatic picture, it's not to be worried about, but in the symptomatic picture, we need to look deeper and find out why that is. And in Chinese medicine, we might say that you had a heart yang deficiency, meaning the yang energy of the heart was weak. It might be a kidney yang deficiency. There's a number of different patterns. We'll take a look at those to see how we would kind of see, why is this person's heart rate so slow? Tachycardia, just the opposite of bradycardia. Fast heart rate, greater than 100 beats per minute. Main things about tachycardia, it can be damaging to the heart. If your heart beats too fast for too long, it's too much work for the muscle, and it becomes a problem in that regard. The main place I see this in clinical practice is with hyperthyroidism. And if you see a hyperthyroid case, where like Graves' disease is the common one that I see, you'll see that the heart starts to beat really fast, 120 beats per minute plus. And if you're over 120 beats per minute for any extended period of time, then you start worrying about the patient, and that can be problematic. So 120 extended period, that's where I start thinking, well, we've got to do something interventionally here to get the heart rate to calm down. But for the most part, again, tachycardia can be associated with all kinds of different things, secondary type of things. Infections are a major cause. Like I said, hyperthyroidism is a cause. Can be other itises, any kind of itis, right? What's an itis? It's an inflammation. So people always say, oh, I have pericarditis, I have myocarditis, I've got tendinitis. It just means that there's inflammation in that part of the body. So in this case, some kind of an itis, a pericarditis, can lead to tachycardia. Supraventricular means it's above the ventricles, so it's in the upper part of the heart. So atrial tachycardia, for example. And supraventricular tachycardias are not the ones that we really need to be worried about. It's when you get into ventricular tachycardia that we start to get into a problem that could be life-threatening. And a fluttering of the ventricles in ventricular tachycardia is a really serious problem. And this is the myocardial infarction. This is the heart attack. This is the person whose heart went into cardiac arrest, and they need an AED, right? An automatic electronic defibrillator to get them out. You've got to shock their heart out of that condition because within an hour, loss of consciousness, fainting, and then soon afterwards death. The heart stops pumping blood to the rest of the body. So it's literally a fluttering of the ventricles to where there is no more movement of the blood. They're not organized. There's no squeezing and moving the blood around the body. It's just the blood is stuck and the heart is in this pulse of this flutter. So atrial flutter is another condition that's very similar to that, but it's more of a quick contraction in the atria, but it's steady. The atrial flutter has been kind of defined as this steady pulse in the atria, but it's just really fast. People will feel it. It'll be very disruptive, can cause all kinds of insomnia, it can be a root of a lot of different symptoms, but it's not as difficult to deal with as atrial fibrillation, which is an uncoordinated quivering of the atria. So it's that uncoordinated activity that causes the main problem here. And this is our most common arrhythmia, atrial fibrillation. You've got abnormal impulses that cause the ventricles to end up being irregular as well in their action. So the whole heart starts to suffer from the atria not coordinating their motion and their electrical impulse. So we're back to that sinoatrial node, gets the signal, it's supposed to go down to the atrial ventricular node, send an even, steady pulse to the heartbeat. But in the atria, there's a problem with conduction. Something's happening in the atria, and conduction's not clear. The atria start to flutter. That leads to fluttering in the ventricles, and the whole system is just working very poorly. Blood is not moving how it should be. Of course, it doesn't feel good either. I haven't felt it, but enough patients have told me how they feel. So atrial fibrillation statistics, like I was telling you, as I dug into atrial fib, I was like, my God, this is a serious medical condition. I mean, there is some serious just medical attention on this subject, because you've got 2 to 3% of the population in North America affected by atrial fib, 750,000 hospitalizations per year, 130,000 deaths per year. The death rate has been rising for more than 2 decades, $6 billion a year spent on this disease. And each person who has AFib costs the medical system almost $9,000 more per year. So wow, that's a lot of resource going into this disease. So then what are the risk factors for atrial fib? What causes it? Well, the number one thing is advancing age. People over 65 have the highest rate of atrial fibrillation. Why is that? Well, I think the heart beats 2.5 billion times in our lifetime. And at some point it starts to get worn out. We all, that's what we're facing in this life, is that things start to wear down. We know that. We have osteoarthritis showing us that our joints start to break down. We have our discs begin to lose the fluids. Synovial fluids become more deficient in all the different locations in the body. Our tissues start to dry up a little bit. We start to get more wrinkled. We have a harder and harder time dealing with adapting to oxidative stress. And the heart is the centerpiece of this again. And remember, its element is fire. It's constantly working and beating and putting out what we call the Shen in Chinese medicine, which is like the spirit of your being. It's manifested in the heart. You say it through your tongue. It shines out through your eyes. It makes sounds. High blood pressure, hypertension, of course, a risk factor for so many things, is a big factor in atrial fibrillation too. We've got obesity, sleep apnea. You can see all the different things here. Obviously, other heart diseases are a big problem. Anything that has to do with the blood vessels failing, the vascular system, left-sided ventricular hypertrophy, that's a big problem when the heart has worked too hard to push the blood out into the rest of the circulatory system. When the circulatory system is either blocked, let's say the liver is really stagnant, backed up, metabolic pathways are slow, or over time we've calcified. We know now that atherosclerosis has a big thing to do with inflammation, but it's also got a lot to do with calcium and where calcium goes in our bodies. And we should be really aware, you guys, of how important it is to get your patients off of high-dose calcium supplement. 500 milligrams a day, that's the top end. Above that, you're starting to cause problems. Not only atherosclerosis, but kidney stones, bone spurs, not good. We don't want to calcify. We're already calcifying. We're headed that way. Let's not increase that. And it's been shown, very, very effectively that they did studies on women trying to see if giving them calcium over periods of time would help increase their bone health. And once you're past the pre-pubescent stage, once you've reached menarche, you basically do not get benefit from high doses of calcium in your bones. The things that help you are vitamin D, vitamin K being number 1, magnesium, manganese, boron, strontium, trace minerals, eating a good diet, keeping off the inflammatory stuff. So, point being, though, that when the arteries harden, the heart has to work harder to pump the blood through the arterial system. They don't stretch as easy. The heart works harder. That puts strain on the heart. The heart's already under strain. So now you just caused a problem that could lead to something like AFib. And when I thought about AFib, originally it's like, well, yeah, people come in, they're taking medication, some of them, or a lot of people, they come in, they don't take medication. They just don't like the way it feels. So we're going to help them out. We'll treat them. But as we get a little further on, we'll see that there are some major medical problems that come with AFib. So what are some of the triggers? Stress. What is that not a trigger for? I told you I work with Donnie for 6 years. I do a lot of work with cancer. Stress is a huge part of that picture, and I'll hit that tomorrow also with prostate problems. Lack of sleep. I can attest myself doing many long nights of studying and all kinds of different things I've done to go all-nighters. Lack of sleep affects you in many ways. You see your neurological function decline. But we also see the heartbeat. If I've ever had palpitations, it's definitely come from a night when I didn't sleep. So mental emotional strain plays into the stress. There's a huge emotional component. Like I said, from traditional Chinese medicine, we see emotions to be directly connected to the organ networks and to how people feel and how the organs function in regard to how we feel. Physical trauma, obviously a huge strain on the body. Surgeries are a physical trauma. So when people are thinking about, well, do I do surgery or not? Well, why don't you try conservative therapy first? Especially if you're 65 years old and you have a little bit of a disc problem in your low back. Maybe we should think about treating you first. Try some chiropractics, try some massage, try some physical therapy, do some acupuncture. If that doesn't work and you're still in pain, sure, but we don't want to put you down. We don't want to go through anesthesia and cut you open and start dissecting part of your body, because you've got to heal from all that. You've got to repair. And anesthesia in people over 65 is also a problem. We know now that it's a big risk factor for Parkinson's disease, Alzheimer's, dementia. So chemical exposures, we'll go through those. I mean, there's just so many of them. You've got the metals, you've got all the phthalates, you've got the chlorine, you've got the dioxins, you've got the pesticides, you've got the herbicides. Thanks Monsanto. We've got alcohol, AFib triggers. And there's been a lot of studies over the years on alcohol and showing, how much alcohol is good for the heart, how much alcohol is bad for the heart, prevent cancer, all these kind of things. And the consensus right now is it seems that a little bit is okay, most of the time. Although in women, it was just shown that there's no benefit to any alcohol at all. Studies are hard to interpret. I'll tell you, from Chinese medicine, we used to give blood-moving herb formulas with a little bit of rice wine because it's a blood-invigorating substance. It creates a movement of energy in the body, especially of the blood, almost like it gets things moving faster. The problem with that is if you do it for a long time, it's very destabilizing. And then the whole system becomes unstable. And that's what will happen if you do too much alcohol, and it will lead to problems in the neurological system, electrolyte imbalances, and then the system starts to manifest problems. Caffeine, we'll look at caffeine a little bit more because caffeine is an interesting one. I'll get to a slide on that and we'll talk about it a little bit more. Alcohol has vagal triggers. Vagal triggers are interesting. They kind of work the opposite as you would think. It's a non-stimulatory type of effect where it's not like in the morning you get the AFib, but it's after you've done something intense and then you rest. It happens during that period. That's part of the vagus nerve and its connection to the heart. And if you think about the vagus nerve and all the places it innervates, we're back to that drawing about the not-so-simple heart, right? How deeply connected the heart is to all the other physiological processes that we have going on. I don't think I need to harp on alcohol too much. We know, a little bit is fun and a lot is probably still fun until you wake up in the morning. The importance of sleep. There's been some really interesting research. Journal of Thoracic Discovery, which was CPAP machines decreased the incidence of AF. I don't think we all need CPAP machines, but there are times when you just get somebody breathing well, get them oxygen, and suddenly they stabilize. It's great. And we can do a lot with sleep too, and we'll talk about that in more detail. I put up here a few useful sleep aids. These are some of the things that I use in the clinic. On the left, just some herbs. Kava is a really nice sleep aid for a lot of people. Passion flower, we know that plant really well. Passiflores, Ziziphus, spinosa, that's a Chinese herb, very nourishing and nutritive, clears heat from the heart, settles the heart. Bacopa, as David was talking about, another Arrhythmias from Ayurvedic medicine, is very calming. Corydalis, Yan Huso, that's an herb that's mostly used for blood stagnation, for moving blood in Chinese medicine, but it's also an herb that has a very sedative effect at high potencies, high doses. Valerian I put up here because it's kind of one of those funny ones that people always say, oh, I tried valerian, didn't work. Like, okay, well, that's because I only use it in the kind of person who comes in, they look kind of like, you're like, does that person need iron? You can just see, they're a little pale, they're like that kind of person. They might do well with valerian, but otherwise I don't find it to be very effective. Heavy settlers, in Chinese medicine we use a lot of things like shells and bones, like fossilized bone. These things, an amber is another one. They're things that just sort of settle down the nervous system with a heavy quality, literally. They're just heavy, and that's what they do. They're not very absorbed. You take in calcium from shells, calcium carbonates, you're not going to absorb them very much. Hey, I know that baby. Hi, Cara. That's my little 11-month-old baby right there. That's Haven. Hi, Haven. I wasn't here last year because that one was getting ready to be born. Hey, Haven. Hey. Hey, buddy. Hey. How's it going? Hi. Hey. Oh, sorry. I'm just learning about the dad thing. Okay. Good God. Okay. Oh, man. Whew. Okay. Constitutional formulas. Now that's really cool. That's good stuff. And David was harping on this a little bit in his last lecture about how important it is as an herbalist to not be a good herbalist, but to be a great herbalist. And what does that mean? It really just means that you're not using the prescriber tradition, which I think should just be done away with. You don't do this herb for this disease. That just is not, everybody goes, oh, what do I do for headaches? Hey, what do I do for menopausal problems? Hey, what do I do for, it's like, that's not how herbs work. That's not how herbalists work. We look at the person, we take some time, we get some information. Then we use our materials to address the imbalances we see in that person. And that's how it works. And you combine herbs into formulas that have this really amazing ability to balance the formula. So you can have one herb that might be a little warm, you can have another herb that's cool to balance it out. If the person needs a warming effect, well, you give them warming herbs. If a person's already hot and you give them warming herbs, you didn't do a good job. You just warmed them up, and then there's a problem. They're getting aggravated. So constitutional formula is my favorite way to address sleep. And so again, a lot of what I do in medicine is address the root of the problem as your foundation, but then treat the symptoms with whatever you need. Like back to the CPAP example. If a person needs CPAP, well, let's get them on a CPAP machine. If a person needs an anticoagulant, well, let's get them on an anticoagulant. And then we can do things down the road to change their constitution, and then eventually they can come off the sort of urgent need of whatever their medication or their therapy is up front. But I don't like to think about these more invasive therapies as a permanent solution. You kind of go to the doctor and it's like you get on a medication and that's just sort of, see you later, see you in a year. Well, wait, what are you doing? I don't want to be on the medication. Can I get rid of the problem so I don't need the medication? Oh, it's fine. We'll see you. We'll check your blood work next year. On the right side, I've got a couple of different nutrients. Glycine, I really like. It's a simple amino acid. It's part of the structure of glutathione. You can't really get too much of it. Again, there's, if you guys get into SNPs, you get into like the Seeking Health stuff, Dr. Ben Lynch and his whole thing, and Amy Yasko, deeply into looking at the human epigenetics and how we metabolize different compounds through our bodies. If you don't know anything about that, it's very interesting. It's just 23andMe is kind of this genetic online look at how you metabolize life through different pathways. So some people with certain substances will have reactions to things. And once in a while, someone with glycine, even a simple thing, like maybe 1 in 30 people, they'll say, oh, I got stimulated by that. It's because of the way they broke that substance down and used it, or because of the way that several pathways were interrelated. Phosphatidylserine, I love that compound. It's a phospholipid, part of the membrane of our cells, just like phosphatidylcholine. It helps to slow down the uptake of cortisol. So people have that kind of, they get up at night, they're just thinking, they wake in the middle of the night. It helps to keep them asleep, soaks up some of the cortisol. Melatonin, we know about that. This is the pineal gland, a regulator. I always think of it as sort of the conductor of our neuroendocrine system. Can be helpful for some people. Dosing anywhere from 0.3 to 20 milligrams in cancer cases. Below that I have phenibut, CBD, and iron. And iron sometimes, if you see that person who really needs iron, iron helps. It stabilizes people. Our blood has a lot of iron in it because that's how we carry around oxygen to oxygenate our tissues. We also have a lot of other elements in our blood. And just a cool concept from Chinese medicine is that the blood is like this anchoring substance. It's related to the heart in that it houses our spirit. It anchors, literally holding, the idea was that it held our spirit into our body by anchoring it down. All the iron, the magnesium, the silver, the lithium, all the things that are the trace elements in our blood that make it rich and allow it to magnetically hold us in our bodies. An idea like you get shot and there's your blood running out of your body, and the kind of profound gestalt moment of like your spirit can't hold on anymore because it's leaving. That whole thing was really profound for me in seeing that and understanding how some of these heavier elements can work in the body to stabilize us and anchor us more. And in people who have what we call in Chinese medicine a Shen disturbance, it's that the disturbance is that their mind isn't clear. They can't quite figure out how to be a normal person. Things are off in their mind, and it's directly related to the heart because that's where the Shen is housed. So it's a long story, but I just want to give you an idea on that. And then CBD, that's cannabidiol, right? Which just recently hit the stores, right? This is one of the cannabinoids from cannabis, and it hit shopping stores all over the country. It was like just a blockbuster. And then the FDA just went, nope, it's not a nutritional supplement anymore, done. So that's now, you can't get CBD from industrial hemp anymore. People still have it, like in Oregon, cannabis is legal, so you can still get CBD, from medical marijuana, but it's a really profound sedative for people. So for sleep, it can be really helpful. That's such a long topic, it's hard to even, touch on it right now. Phenibut, This is, I know I was looking over Kenneth's lecture, and phenibut was something he's going to talk about too. It's a really cool substance. It's a GABA agonist, right? So gamma aminobutyric acid, that very calming neurotransmitter in our brains. It stimulates that receptor. It's an agonist for the receptor. It works really well. It's similar to GHB, gamma hydroxybutyric acid, which was the date rape drug. And GHB was the thing that affected this other receptor called the GHB receptor in the brain, which leads to like a deep trance, like you're gone, you're just out of your body. And that's where that drug got its kind of fame with the knocking people out. But this substance, phenibut, doesn't do that. It just affects the GABA receptor, and it just has this real calming effect on the body. And I find that often people do really well with about 600 milligrams before bed. And it's one of those things where you've isolated a compound, you're focusing it on a receptor, so you don't want to do it every day. It will eventually, you'll need more of it. So anytime somebody does something and then they need more and more, we need another solution. It can be helpful, but with sleep, I find you've just got to keep switching what you do. Just keep changing it up. People say, I did this for 3 days and it doesn't work. Well, that doesn't mean that you failed. It means that you need to go to another aid, go to something else. And then when that doesn't work, go back to the other thing, and then it works again. And you can find a nice little cycle for people that works really well. I found that to be really helpful in practice. Caffeine, I talked about that. And this is back to the SNPs, right? SNP, single nucleotide polymorphisms. These are regions in our genetic code that basically code for certain enzymes that produce proteins. Some of those proteins act as enzymes. Those enzymes denature other proteins. Caffeine is metabolized through the CYP1A2 pathway, which is encoded for by RS762551. That's the place where we find if people metabolize caffeine slowly or fast. So the AA person who has the CYP1A2 AA gene, that person is going to take in caffeine and they metabolize it fast, they excrete it, it's good, they're done. They do really well with caffeine. The person who has the AC or the CC, and the CC is the slowest, that's the homogeneous, right? That's the homozygous alteration on the gene that says that person just really doesn't do well with caffeine. And the other people that won't feel well, they'll take caffeine and that caffeine will just keep circulating. They just won't break it down and they'll keep getting a stimulating effect from it. Those people shouldn't be doing much caffeine. So to just, again, it's like, is caffeine good? Well, maybe. Might be good for you. Might be okay for you. It's hard to say. We need to do more research. So, and you can figure this out with people too. I mean, people tell you, yeah, I mean, I have a cup of coffee and I just feel crazy. Well, that's, don't drink coffee. Unless you want to feel crazy. I mean, this is just a little diagram just to go, we're going to go a little deeper into AFib here. So the normal heart on the left and then a heart and AFib on the right. You see the conduction, the sinoatrial node, AV node, down the bundles, through the Purkinje fibers. Everything is beautifully choreographed. The heart is such a beautiful structure when you see it pumping. The atrial fib, you see where the main problem is up there in the sinoatrial node, where it's going over into the AV node. This is all, the signals are all kind of, they're just screwed up, where they're going all over the place. And we talked about causes, right? We talked about what some of the triggers are. And it leads to problems in the ventricles. And that's the thing. That one of the concepts in AFib in cardiology is protect the ventricles. So whatever you do, don't let the ventricles get out of control. Not only is it going to wear the heart out, but it's also going to lead the person to the potential ventricular tachycardia in which they can die. So classes of AFib, there's several different ways that we've defined it. One diagnosed episode, that's first detected, paroxysmal. They come and go, but they don't last. Persistent, hanging in there for a long time, and permanent, just you're always in AFib. The heart is always in AFib, so you're always having that feeling. The heartbeat isn't quite right. It's affecting blood flow throughout your whole body, and those people are really suffering on this level. It's really frustrating for them. A lone AFib it just happens out of the blue, and that can often be caused by some other cause. And then non-valvular, talk about the valves. Prolapse of the valves is one thing where the valve gives out. It's no longer, doing its job of becoming a backflow valve, preventing blood from going back through it. It can be a regurgitation where some of the blood is slipping through. It can be stenotic where it's hardened and it's not opening and closing effectively. All those valvular issues are kind of a different thing overall. You look at those as valve problems, but they can also be a part of the AFib picture. And if they are, they got to be addressed. And I'll tell you that they're not just going to be addressed by addressing the heart, but by addressing the whole body, the whole physiology. And then secondary causes we talked about: hyperthyroidism, inflammation, pericarditis, infections. So this is the big deal with AFib. The most common cardiac source of emboli and cardioembolic stroke of anything. That's a pretty big deal. So what happens? So when the atria go into that fluttering, when they stop pumping the blood into the ventricles and the blood is pooling, under that pooling effect, it's like there's an eddy and the stream isn't moving fast, and blood wants to be moving. It's always in motion throughout our bodies. So it starts to lead to this coagulation that starts to happen. And you get this coagulation leads to a clot. That clot is in the atrium, and now you've got a little clot that formed, and then that little clot, when you come out of AFib and it sends the blood, that clot goes into the ventricle. When that clot goes into the ventricle, it goes out into the aorta. And then it goes out into smaller and smaller and smaller and smaller vessels until it lodges somewhere and causes hypoxia in the tissue beyond it, right? You guys understand that? Real simple, right? That's a big deal. And strokes and TIAs, of course, little vessels in the brain, this is a big problem. So when when somebody comes in with AFib, I want to make sure we're thinking about this, because cardiology makes it into a very big medical problem, a big deal. So this is a really cool slide that a friend of mine and I put together. These two things, the CHADS score was the older version, and then the newer CHADS 2 score. This is how they evaluate stroke risk in the cardiological realm. So basically, you can see here the 0 means that the person needs no anticoagulant therapy. There's nothing here that says that, but just if you were like you or I, we don't need to be on anticoagulants, right? Our body has a system for regulating the clotting versus non-clotting factors in our blood, so we don't need to be on a coagulant. This right here, these gray boxes are associated with a number 1, because once you get this score, you're evaluating whether you need to be on an anticoagulant or not. And if you have a score of 1, means any of these gray boxes, you have any one of these are important. Anybody here, woman over 65? Are you on anticoagulant? Well, according to this, you probably should be. You should consider it, because you're at risk. If you had AFib. You guys don't have AFib, that's true. So if you have 2 of these, 2 of the grays, that equals 2, or any one of these red markers, you have a score of 2, which means that you are recommended, not just should be considered, but you're recommended to be on an anticoagulant. So just take a look at that. Any one of these things. If you have high blood pressure, that's 140/90, right? If you've got congestive heart failure, diabetes, vascular disease, if you're age 65, if you're female, and then either of these things, the biggest risk factor of all is the prior stroke. And if you're over 75, you already have 2+. So if your patient comes in with AFib, and you're looking at them, and you've got to consider all this stuff. Because if you've got a 65-year-old woman coming in with AFib, she's already got 2. So according to the modern medical assessment of that condition is that if she has a stroke and you are the primary care provider, you missed it. Right? That's why I say it's a pretty serious deal. We don't want to just say, hey, we can treat this, we got this. It's natural medicine, we got you, you're cool, we're going to do this fine. Just make sure that you evaluate the patient, let them know, and make sure that you're both in understanding that the recommendation is that they should be on an anticoagulant. AFib, 65-year-old female. I just thought this was really important. I was like, I didn't realize it was so intense, because I've treated a lot of AFib. So, warfarin. I mean, it works, right? It reduces the risk of stroke in patients with AF by approximately 2/3. What are the downsides? Bleeding complications, gastrointestinal bleeding. It's one of those drugs that we don't really like, but it works. It works through working with vitamin K and inhibiting vitamin K in the cell. And vitamin K, which, the word K came from the discovery that substance, that vitamin, affected coagulation. It was a German guy, so it was K, coagulation. That's where we got vitamin K. I'm just going to kick on to the next slide and just tell you a little bit about warfarin. So what's interesting about that drug is when it was found, it was these farmers in Wisconsin and people who were raising cattle. They needed to find a cheaper solution to their feed, and so they started using clover, sweet clover. And the sweet clover, when it dried and it was in bales, it still was kind of moist. And so when it grew this little fungus on it. And this little fungus had this really interesting stuff in it, and these cows started to bleed out. They didn't know at first. They just saw these cows would just start bleeding. They'd bleed out of all parts of their bodies, and they would die. And they're like, what the heck is going on? So they were like, some researchers researched it. They figured out, oh my God, there's a compound in here. If there's a fungus, and we've got this stuff. And they eventually decided to make it into a rat poison because it worked so well. They could poison rodents with this stuff, and they would bleed out and die. Well, eventually, it got turned into a medicine because it worked so well. If you control the dose, you can just get it just right, and then tweak the molecule a little bit. We can get it so that it works really well for stopping bleeding. I don't like that drug. It takes constant monitoring. You've got to go in every 2 weeks, get your INR, your international ratio. You've got to get your prothrombin time. You've got to make sure that everything is perfect. And people just hate being on it. My patients are just like, God, I hate being on warfarin. I hate being on Coumadin, and I don't want them to have to go on it. So there are other options. But for the most part, it is, again, it's just one of those things that it works, and cardiology uses it for that reason. So Asian people have a much higher complication of bleeding with vitamin K inhibition. It's a very real issue. People bleed out with this stuff. So we need to be really, try to get people off warfarin if we can. And I wanted to talk about how do you do that, because there's a lot of fear around warfarin and how to work with it, and all the possible interactions that can happen. And so we'll just jump onto this next slide, which is vitamin K, leafy green vegetables. The most interesting thing to me with vitamin K in warfarin is that low doses of vitamin K in patients taking warfarin have been shown, multiple studies, to stabilize their INR, so that they're actually getting a more even and controlled response to the drug. So patients would come in and say, oh, my doctor said don't eat any greens, don't eat any broccoli, don't eat any, I don't want you doing any vitamin K. That doctor is making that person less stable. You're destabilizing them. And they're at a higher risk of bleeding complications because vitamin K is needed everywhere in the body to stop clotting. So you want your patients to do vitamin K in the form of foods every day. But it wants to be consistent. So you don't want to just eat a ton of vegetables one day and then eat nothing the next day. You want to make sure the person kind of understands how much vitamin K is there in the foods, and then get them eating the right amount of those foods every day for their health, and then monitor their INR. And if you adjust their warfarin dosing, that's great. That's what will happen. And so as we use compounds to help people, we use plant materials and things to treat their issue with clotting. With vitamin K, I'm always of the opinion that if we can change their INR so that they need less drug, that's great. That's not a bad thing. Oh, you affected their INR. Stop it. Well, what happened? Their INR went up. They need less drug. Well, that's good. It's rat poison, right? Less rat poison is good. That's the way I see it. I mean, that's just me. So these are non-vitamin K inhibiting oral anticoagulant drugs. Pradaxa, you'll see that one out there in practice now. That's one that comes up a lot. Problem is, it causes a lot of GI symptoms, dyspepsia and heartburn. And what's the problem with that? Well, the problem with that is, how are those people treated for that? Proton pump inhibitors. Somebody said that, right? Right. What's the problem with that? Magnesium deficiency. Yeah, that's one of the main things. One of the main problems with atrial fib is magnesium deficiency, which we'll get to. So this, we don't want people to have to be taking drugs that then lead them to problems, that then lead them to use more drugs that cause more problems and lead to bigger health issues down the road. What does it do? It inhibits thrombin. Thrombin is going to trigger the fibrinogen to become fibrin, to make strands of fibrin in the blood, which is then going to combine with the platelets that aggregate around the fibrin to create the clot. Okay? Lower risk of mortality, but more gastrointestinal bleeding, so it's still just not a good solution. It's just really not. So I wanted to talk about some natural blood stasis and clot-inhibiting therapies. Natto, lumbro, ginkgo, essential fatty acids, turmeric, and using a botanical formula from Chinese medicine. Some platelet inhibitors, ginkgo. I think ginkgo, we could talk about it a lot. Intracellular calcium levels are a big part of the clotting cascade. And calcium, obviously, we know, is a big part of neurological conduction, muscle action. By inhibiting intracellular calcium levels, we can inhibit platelet activation. That's what ginkgo does. It does it pretty well, and it's been thought that ginkgo could be used as a platelet aggregation inhibitor. Not a lot of great data on that, but it is one of those things that ginkgo in really high doses can lead to problems if you combine it with other things, like let's say whole brain radiation, for example. I wouldn't give people high doses of ginkgo biloba if they were doing whole brain radiation. But in most cases, I'm not worried about it. It's not going to cause a problem unless you have a major other intervention that's affecting the vasculature and the clotting cascade. Aspirin is another story. Now, it's important to understand that aspirin is salicylic acid, right? Derived from salicylate-containing plants, like white willow being the primary one. But what happened to aspirin is it was irritating to the GI tract, so pharmacy decided to make it better on the stomach and make it less damaging and more palatable, so they combined it with an acetyl group. They stuck an acetyl group onto salicylic acid and called it acetyl salicylic acid. Now you can take it, and you don't get the gut problems. But what it does is it deacetylates the platelets. So platelets live for how long? Anybody know? What's the life cycle of a platelet? 7 days. Platelets are born out of the bone marrow, right? And they live for 7 days. And in that 7-day period, if they come in contact with aspirin, they're deacetylated. Now they don't connect to other platelets anymore. They don't aggregate. So that's how aspirin works. Now, salicylate-containing plants, if they do have anti-clotting activity, it's not because of their acetylation. It's because they have other actions, other compounds, similar to like ginkgo or something else. But the salicylate-containing plants don't do the same thing that aspirin does. I just want to make that clear. Aspirin is its own thing, and it will inhibit platelet aggregation, and it is used as a clot-inhibiting therapy, and it's very effective. So any platelet that comes in contact with aspirin will no longer connect to other platelets. Two of my favorite fibrin-digesting enzymes. Chinese medicine, again, what a great thing. Earthworms. So inside the gastrointestinal tract of the earthworm is a group of enzymes, one of them called lumbrokinase. Lumbro from the earth, right? Lumbro, earthworm. Lumbrokinase is used by the earthworms to digest the materials that are in the earth, the cellulose, all these big fibers that they have to go through. They're eating through the earth. That's how they do it. They make an enzyme. Nattokinase is an enzyme found in natto miso. So natto, a serine protease, has thrombolytic properties. It's a fibrinolytic enzyme, digests fibrin, reduces hypertension, and it resembles plasmin. And plasmin and plasminogen are going to do the opposite of thrombin. They're going to go the other way and help break down the fibrin, the fibrous clots. It doesn't have a long half-life, so you've got to dose it frequently, every 8 hours kind of being the minimum. And there's 17 studies that I found with nattokinase showing it being effective to reduce coagulation, including 2 small human trials. Dr. Milner, he's got the Center for Natural Medicine up in Portland. He did an article in Life Extension some years ago, and it was really cool. He just talked about nattokinase at length and gave his dosing. A low dose, 100 milligrams, that's 2,000 fibrin digesting units, FUs. Medium dose, 2 capsules 2 or 3 times a day. High dose, 3 to 4 capsules 2 or 3 times a day. And these are 100 milligram capsules. So when you're looking at a nattokinase material, make sure that it is 100 milligram capsule. Make sure that it has at least 2,000 FUs, fibrin digesting units, okay? And then you can dose it in any one of these areas. And again, with this substance, it's going to act on fibrin itself. It's not going to act in the blood to cause bleeding. There's no reports of bleeding out from nattokinase. You're not going to eat so many soybeans that you bleed. But it's really a powerful substance, and it works really well. And again, you're going to see that the lumbrokinase nattokinase action is different than the warfarin action in a major way, and different than Pradaxa, and different than the heparin-like compounds, different than Herudins and things. They work as they digest fibrin, and that's really cool because they don't have to be used with such caution. They're just not they act in the presence of fibrin. So lumbrokinase also activates plasminogen, which then breaks down the clots. Plasminogens are released by the liver, and it's another serine protease dissolving fibrin. In cancer, we look at a marker, this is one of Donnie's things, called plasminogen activator inhibitor 1. And it's a compound that inhibits plasminogen. And it's a good marker because it shows that coagulation is increasing in the body. And cancer patients are at high risk of blood clots. It's 10 times the risk of a blood clot in just in a cancer patient, 7 to 10 times, just by having cancer, because it's a disease of stagnation, of blood stagnation. Lumbrokinase dosing is a little different. There's 2 different companies that make lumbrokinase right now. One is Canadian, Boloki, and one is Allergy Research. And I dose anywhere of those capsules, anywhere from 1 capsule 3 times a day. Yeah. Allergy Research Group. ARG. They're the only 2 companies that have lumbrokinase right now. And both of these enzymes have been shown to make it through the gut to some degree. So they're definitely going to make it through the digestive tract and make it into the point where they get into the bloodstream. Again, works only in the presence of fibrin. I was going to say dosing, though, 1 to 3 caps, up to 3 times a day. So high dosing, cancer case, you want to digest the fibrin. Person has a clotting situation like this, I might do maybe two caps 3 times a day of both lumbrokinase and nattokinase to eat up all the fibrin in their blood. Problem is, if you don't address their AFib, they're still going to be having that eddy effect. It's always going to be happening, so they have to stay on whatever medication they're on all the time. If they have a deep vein thrombosis and there's still clots in there, the body hasn't rerouted, there's still going to be pooling of blood behind those clots, and that's still going to be a problem and can still lead to issues. So you've got to, again, address the underlying problem. Here's just a couple of the studies that came out on lumbrokinase. It's just for you guys to have if you want to take a look at it a little deeper. TCM Botanicals. These are the 3 different levels of Chinese medicine, the way that we approach blood stagnation. One is just to invigorate the blood. Simple things like angelica, ligusticum, red peony or white peony, the radix mouton. They gently kind of move the blood and stimulate blood flow, oxygenate the tissue. The next layer is herbs that remove blood stasis. Jianghuang, that's turmeric, right? Turmeric is like one of those mid-range. It's really a blood mover. And that's why we think of it more than being an anti-inflammatory, because turmeric is warm in its nature. So if a person has inflammation and they're kind of a hot person, there might be other things that are even better than turmeric for their kind of inflammation. What's causing their inflammation? Arrhythmias flower and the persica seed. Salvia miltiorhizum, I'll talk more in detail. That's one of my favorite plants, especially for the heart. Great for the heart all around and great to help inhibit clotting. And then these 3 at the end there, the breaking blood stagnation. This is when clots are forming and the person really needs something strong. The Zetoaria, Sparganium, and then the leech, which I want to hit. And the leeches have a compound in them called hirudin, which has been deeply studied. Now, of course, the leech attaches onto the body, right? The leech needs to draw blood through the tissue. And how does it do that? Well, it has to release an anticoagulant in order to let the blood keep flowing. Otherwise, it'll coagulate and it'll get stuck. It won't be able to pull anything in. So its compound, they're called hirudins. So it releases hirudins. So Chinese doctors used leeches. They would dry them and then make them into decoctions. We still have this medicine. It's available right now. You can just go ahead and get it. It's called shui zhi. I have it in my clinic. But the leeches are harvested. They're dried. They're cooked in a traditional fashion, decoction, and that is dried out into powder, and then you use that, and that has the hirudin in it, which is a nice way to break up clotting in this way. It's just that it's hard to monitor it. You just kind of need to know what you're doing. But you could you could add it to a formula, and it becomes a great part of the whole formula as far as inhibiting clots for people. Yeah, I'm going to hit that right here, right one of the next slides here. Let's see. Yeah, herb-drumming interactions is the next slide after this one. Some natural platelet inhibitors, things that we all eat all the time. Good stuff. So more of all those things, maybe, except for the wine and beer. Just keep it minimum. But again, it's and this is something that Chinese medicine has known for thousands of years. Literally, give people wine, it invigorates the blood. It reduces blood stagnation, and now we know. Well, there's actually a platelet inhibiting effect from beer and wine. So herb-drug interactions. This is a Medscape article that just came out about a year and a half ago. Currently, there are no reports of bleeding associated with concomitant administration of warfarin in any of these herbs. Let's take a look at them. Angelica, arnica, anise, celery, chamomile, fenugreek, licorice, lovage, parsley, red clover, rue, meadowsweet poplar, willow bark, ginkgo, bromelain, clove, onion, turmeric, borage seed, bogbean, and capsicum. And there's a lot of other plants that don't really do much. The problem with thinking that herbs are going to interfere with warfarin is that warfarin inhibits vitamin K uptake. That's what it does. Herbs don't do that. You can't find an herb that has enough of a compound that would just block vitamin K that it would just make warfarin into this insane, compound, and the person starts bleeding. So a lot of the hype around warfarin interactions has been blown up because of safety concerns, and understandably, this is a concern. We don't, doctors say, I don't know, so don't do anything. But at least we have some good studies coming out now saying that, yeah, we've done the research. We looked at this. We looked at these combinations of herbs with warfarin, and there's no problem. And I don't know if you guys have done this in your own practice, anybody who's a practicing doctor here, but if you have people who have an INR monitoring system and you get them on a lot of herbs, their INR doesn't change. It's very hard to change someone's clotting time with herbs. It really is. I've tried. Yeah, keep consistent, whatever you're doing. So if a person takes a regimen and there is a change, then make sure that it's adjusted for and they stay on the regimen. Then you've got the right dosing. And again, the goal is less rat poison for my patient. Okay, so how do we treat AFib in modern medicine? Cardioversion's number one. What does that mean? That means that you give people drugs to stop the heart from beating out of control. Radiofrequency ablation, that means you destroy part of the heart to make it work so that it doesn't conduct these rhythms, these electrical impulses that send the heart out of rhythm. Or surgery, which is basically you go in and you cut the heart to cut off parts of the interactions. Hey, did I answer your question? I'm sorry. He does actually. There's a clotting test he does. Uh-huh. Right. Right. Yeah, and what she's asking is she's saying, hey, monitoring is really important because if you're not looking at the INR, how do you know if it's being effective or not? How do you know what's happening with the patient? Is that what you're saying? Yeah. And I think, in Dr. Milner, he does a very specific thing. He uses a blood pressure cuff, a little lancet, does a controlled incision, uses clotting paper to touch the side of the drop, does it every 30 seconds, and he calls this the patient's actual bleeding time. So it's a physical test where he uses a normal reference range, about 2 to 8 minutes it should take before that clotting stops. But he says that he sees a lot of patients at 2 to 3 minutes, and he tries to shoot for 4 to 6 minutes. And then if you guys want that information, on the Life Extension website, there's the article from Dr. Milner that goes through how to do that, how to use the blood pressure cuff and use a lancet and watch the drop of blood with a little piece of clotting paper. And you can do that if you feel confident in monitoring something that way. The problem is that you never know that someone's protected, if they're not doing monitoring. And so if you're treating a patient with AFib, that's why I say if they have those risk factors and they have AFib, they need to be monitored. They need to be on a drug. That's the medical recommendation. So if you're going to take that on, don't take it on lightly. It has to be the patient's choice. If the patient, I have patients come to me and say, I do not want to do what my cardiologist says. I'm not going to do it. Can you please help me? And I'll say, I can help you, but I can't guarantee that I'm going to do what your cardiology drugs would do. And as long as there's a clear understanding and we've got consent, then I will treat them. But I'm not confident, like she's saying, that I have controlled their problem until I've done the monitoring. And that's where we get into the issue. And that's why this is a tricky little thing. But again, if their AFib is under control because you've corrected their problems, all those stressors and lifestyle factors, then they don't have the recommendation anymore because they are out of AFib. Understand? So if they need to go on warfarin or on Pradax or something else, and you get their AFib under control while they're on the drug, because the drug doesn't stop the AFib, it just stops the clot from happening in the eddy, then you've done them a great service, and they can now come off their drug because they did an ECG with their cardiologist that said, hey, my heartbeat is normal. I did a Holter monitor for 2 days. I didn't have one AFib episode. Great. Let's talk about reducing your warfarin dosage. So thanks for bringing up that point. I really appreciate it. Okay. Where are we here? So cardioversion, you can either electrically shock the person. They're coming in. They've got their heart is off. The beat is out of control. You shock them. It shocks their heart back. That's the goal. You've seen this in the movies. Chemical cardioversion, these are antiarrhythmic agents. This is part of the pharmacy credits here for this class. Make sure that we have the different classes of antiarrhythmic agents. Look where they target: sodium, potassium, calcium. So we're working on electrolytes. And so electrolyte imbalances are a big part of the AFib picture. So these drugs often target electrolytes and block them in order to change the way that electrical impulses are being conveyed in the heart. Class 1 are the canes, the lidocaine, procaine, and propafenone. These have some potassium blocking activity too, and although the procaine and lidocaine, those aren't too bad. Their side effect profile is really low. They're not nearly as effective as some of the other things, especially in AFib. Beta blockers we're all pretty familiar with. These are the beta adrenergic receptor inhibitors. Potassium channel blockers, amiodarone. These are often, they have a lot of different actions. They're not super specific for potassium. Calcium channel blockers like verapamil. We know those for a lot of those for hypertension. And then class 5, things that work by unknown mechanisms like adenosine and digoxin. Beta blockers and calcium channel blockers are the most commonly prescribed for AFib. So we'll talk about beta blockers because I've got patients just come in all the time on beta blockers. It's just very common to see people on them. And what do? They block the catecholamine action on adrenergic beta receptors. So under the stress response, a person is excited, their heartbeat gets faster. Beta blockers stop that from happening. I always like to consider it being like putting a governor on, if you've ever ridden a moped or something, like in the state of Minnesota when you're 15 years old, you can get a moped, and the moped can only go 30 miles an hour. So if the motor would take you 35, they put a little device down on the motor that says it can only open the fuel so much and you can only go so fast. It's just like that on the heart. You get excited to go do something, not happening. 30. Only 30. So people feel really like they don't feel good on beta blockers, because I can't get excited about stuff. So if they work really well, but they have that downside. One thing is the beta 1 receptors, they're located in the heart and kidneys, and so certain drugs target those better. Metoprolol, atenolol, those are the two main ones I see. There's the bisoprolol and the nebivolol. Those are also used in cardiology, but I pretty much see metoprolol and atenolol almost exclusively from cardiology with the cardioselective beta blockers. Interesting to know how profound that effect is on people. If we can do that effect, if we can create that beta adrenergic receptor inhibition without beta blockers, we're like, man, we're doing the work of doctors. We're really doing, this is what we want to be doing, because it's that stress stimulation that leads to dysfunction and dysregulation throughout our bodies. Why? Because we're made to be stressed for a minute, for 5 minutes, for an hour. We're not made to be stressed every day, all day, on the phone, in the car, in the office, in my bed, thinking, oh my God. That's not okay for us, and it leads to these things: breast cancer, ovarian cancer. So in these two different cancers, there were two different studies done, look at it, 2012, 2015, that looked at women who had these diseases and who were treated for them, and they took one group and put them on beta blockers, and one group and didn't put them on beta blockers. And in both studies, the women who were on beta blockers had much better outcomes. Progression-free survival, overall survival, rate of recurrence, aggressiveness of disease, all of those things were affected positively by them being on beta blockers. Well, I'm not saying everybody go on beta blockers, but I'm saying let's do that. Let's do that work. Let's control the beta adrenergic stress response, and we will see people stay well and be well. Calcium channel blockers, amlodipine, we see that one for hypertension. I see that one a lot. Verapamil, that's kind of one of the more common ones that I see also. That's a real selective one for the myocardium, so more with folks with the atrial fib. Diltiazem, those are the benzothiazepines, obviously not the benzodiazepines, a very different class of drugs. Cardiodepressant, vasodilating. And then we've got the gabapentin here, Neurontin, and pregabalin. Those both have an effect on the calcium channels as well. Gabapentin is sort of the pharmaceutical example of phenibut, which I talked about earlier. Gabapentin is given to people mostly for neurological pain, neuropathic pain, but it also has an effect here, blocking the alpha-2 delta subunit here of the voltage-gated ion channels to induce this sort of, again, calcium channel effect, beta blocking effect. You want to block some of these receptors that trigger the heart to beat fast. And then alcohol also has some interesting effects as a calcium channel blocker, And then we go back to kind of how it had those counter effects, though, as a vagal stimulant. Amiodarone, the primary calcium channel blocker here, it came from an herb. It came from Kella, David. So the progenitor molecule is Kellan. The guy who found, Kella, I don't know if you guys know the herb Kella, but it's a popular herb. We use it, I pretty much use it for vitiligo. It's also a muscle relaxant. But this compound, Kellan, was a very muscle relaxant compound, and this drug is modeled after that because its effect on the calcium, or the potassium channel was really profound. So this is a variation of that molecule. It's not one you're going to find a lot used in, people coming in unless they've done surgery. They're post-surgical and they need some serious help. It's just got a lot of side effects, and it resembles thyroxine, which is a problem because thyroxine is T4, and if you get a lot of T4 in your body, the effect is that you get hyperthyroid-like effects, which is what? Which is, that super high heart rate again. Adenosine, this is a compound our body makes. It's also something that's been shown to be caused by acupuncture. Acupuncture has been shown to increase adenosine rates. We're not sure if it's because the needle piercing the skin actually just caused the body to have that response locally or if it actually triggered something neurologically. But it's interesting to note, adenosine is kind of the opposite of caffeine. So it's actually antagonized by methylated xanthines. So caffeine actually works to stimulate you by inhibiting adenosine. So giving a person adenosine, it relaxes the blood vessels, it relaxes the heart, it calms everything down. Here's the similarity. You see the caffeine molecule, then up on the right there, the caffeine part of the adenosine molecule, very similar, but having this inhibitory effect. So here's some powerful plants. Digitalis. This is a great plant. We used to be able to get digitalis in the herbal apothecary, no problem. But nowadays we can't because the FDA came out and they pulled about 3 or 4 of our favorite low dose, narrow therapeutic index drugs or plants off of the shelf because they were now shown to contain compounds that were pharmaceuticals. So you can't use them. So you can't get them anymore. But digitalis is a really cool plant. It was the source of digoxin, and digoxin is a really incredible compound that's been around for about 200 years. Guys like Ellingwood and King, all those guys really, they used it. It does have a problem increasing the risk of death if it's not used really appropriately. And they did create another version of it called lanoxin, which is a synthetic version that's a little bit better tolerated, but still the same. You have that narrow therapeutic index again, where the effectiveness and toxicity is, those two dosages are really close. In fact, with digoxin, there are antibodies, the anti-digitoxin or digoxins out there. Digifab is one of them that's used to, if the person gets too much, you have a way to quickly bring them out of the heart problem that they're having. Basically, they're going to go into, this is increasing myocardial contractility. And it's an amazing substance because what it does is it actually inhibits the sodium-potassium ATPase, the stuff that breaks down the ATP that's being made through the sodium-potassium pump. Really cool. It allows the heart to beat with more force at a slower rate. It increases the contractility, which is so cool. And that's what's so cool about digitalis, because the plant, Digitalis lanata, has that as well, the cardiac glycosides, of which digitoxin and digoxin are cardiac glycosides. Ellingwood described digitalis as being the direct heart stimulant, and it was really for older people whose hearts were just congestive heart failure, hearts just not, it's just the weak heart. You could use digitalis or use digoxin to support it, make the force stronger, and the people feel a lot better, and they get blood flow and perfusion all over the body. It's really quite a profound substance. It's just that, again, the dosing is really narrow, so you have to be really careful with it. Another cancer note there was just that HIF1 is hypoxia-inducible factor 1, suppressed by 88% in an in vitro study that was for reducing hypoxia. So again, oxygenation of the tissue. That's kind of what this is all about, and that's what this plant is so good for. Foxglove, if anybody doesn't know this plant. So that's why you always have your kid, don't eat the foxglove. So some invasive therapies that are used here, the Mays procedure, open heart surgery. This is a person with AFib. You basically go in and take a scalpel and you cut little holes, little slices across through the nerves in the atria. You've opened the heart up, splayed it out. The person's alive. They're under anesthesia, and you're slicing apart their heart, and then you put it back together, and then they're all good. AV node ablation, that's the atrioventricular node. You go to the node there and you destroy the tissue between the atrium and the ventricles. And then radiofrequency ablation is where they use a radiofrequency pulse to destroy the nerves at the pulmonary veins. We saw where the pulmonary veins come in to the heart. They come in right there to go into the left ventricle so that we can get blood that's been oxygenated out into the body. They come into the right atrium. So catheter ablation is a really interesting thing. So they bring a catheter in through many different places. Inguinal is one area. They come in, and so you first go in and they use these catheters to diagnose where the problems are. They measure electrical impulses. Then they go in with the catheter and they start ablating these little areas, the tissue, where they can see that there's like this aberrant firing of nerves. This, of course, is less invasive than the maze procedure, but you're still going in. You're going under and you're getting stuff through your veins, and they're ablating parts of your tissue. It's not a simple procedure. Pulmonary vein isolation is sort of the next evolution of this, where you took the catheter and you're just kind of hitting those points where the pulmonary veins come into the right atrium or the left atrium, and you're just trying to stay right at those places because that's kind of where they've targeted the main aberrant electrical firing happening in atrial fib. One of the things about these things is that with ablation, you're walking in. This is a patient who walks into the procedure, right? They walked in. Okay, this is a $100,000 procedure. Okay, there's a little quote here. They will endure 2 to 3 hours of general anesthesia, vascular access in both legs, 2 transeptal punctures, a fluid load, and purposeful damage to the heart done in proximity to the esophagus, phrenic nerve, pulmonary veins, and the thin left atrial appendage. The $100,000 procedure, with its real-world 5% to 7% risk, often fails. Repeat procedures required in 1 of 4 patients, and the most important factor is 1 in 1,000 people die. 1 in 1,000 people die. It's generally effective and safe. And the other thing is, once you go through this, then you get this guy. You got a pacemaker. You don't walk out. You walk in there and you get you go through the procedure, and then you get a pacemaker. So, pacemaker basically, the technology is improving, but there's all kinds of issues with pacemakers too. And people have they have sensitivities to the materials. People get infection. There's all kinds of problems. Like I said before, a lot of times the atrial fib catheter ablation doesn't hold. It doesn't work. 1 in 4. So you got to go back in and do it again. You've got the pacemaker now for the rest of your life. And what's really profound is this really a disease? Is this really worth the $100,000? Is this really worth the surgery and everything that goes on? This is a wrong target problem. The AFib is the barometer in the heart telling you that something is wrong. Something else is the reason. Lifestyle diseases, proper diet and lifestyle changes. We can even regress fibrosis in the heart by getting people to lose the weight, to change their lifestyle, get off the drugs, get out of the way of the chemicals, get the stress out of your life. These are the things that are going to change their outcomes in huge ways. So we don't have to get them doing these procedures. Just some studies here. Aggressive risk factor reduction has shown huge impacts in people. These are people that were going in for radiofrequency ablation and who had weight control, basically a body mass index control, and just had a huge improvement. Long-term weight loss, maintenance of sinus rhythm, 5-year follow-up on the legacy study. So what do? You use antiarrhythmic therapy as a short-term approach to stop the arrhythmia in the moment. If that person needs to be on a drug, unless you can control it with something, you can control with plants, address their other lifestyle issues, sleep, alcohol, over-exercise, overwork, stress. Then what does that do? It'll improve everything. It'll improve the health of their life. One of Donnie's phrases is, you come to me with cancer, he'll say, the first thing I'm going to do is I'm going to make you healthier than you've ever been in your life. That's a really profound statement, and it's a really great way to look at people, because no matter what they're coming in for, it's our job to help them get well, all the way around. And then their other problems will resolve. So Chinese medicine assesses AFib. We look at the constitution of the person. We look at their pulse, check out their tongue, give them a full system review. This is an AFib, right? Where this person comes in, I've got atrial fib. Well, we're going to find out who this person is and what's going on with them on as many levels as we can. Pattern differentiation. I talked about something like kidney yang deficiency, heart yang deficiency. That's the way I would see it as one part of my diagnostic tools. Then you find your treatment principles. What are the principles I want to apply here? Then you use a multimodal therapy. So Chinese medicine has 8 simple principles. Is the problem yin or yang? Is it a yin disease? Is it long course? It's been happening for a long time. It's slow. Is it yang? Is it fast? Did it just occur last night and it's just flaring up? Is it hot or cold? Does the person have heat symptoms, heat signs, or do they have cold signs? Is it excess or deficiency? Do they have a pounding pulse? Are they red in the face? Do they have headaches and high blood pressure? Or are they cold and deficient and frail? Is this an internal condition or external condition? Is this something on the surface? Is it something they contracted? Is it something that's coming from the inside of them? So just to give you an idea, some of the patterns that we would look at just to see, how would we understand how AFib is occurring in this person? Any one of these things, plus many more, could be the reason why they have AFib. And if we correct these problems, they're going to get well. So treat the whole person. We'll jump into botanicals. Is it too much or not enough? This is an excess tongue. You can see it has a very thick coat. It's kind of yellow. It's kind of sticky. It's hot. This person has an excess condition going on. This is a deficiency tongue. The tongue is puffy. It's pale. It's kind of flabby. You can see it's got tooth marks along the sides. Important to know if it's excess or deficiency. And it's not something that you often learn in naturopathic school or medical training of most kinds. But I highly advise you guys to take a look at it. Just get some basic understanding of how to see, is this excess or deficiency? So some heart tonic herbs. Hawthorn is probably my all-time favorite heart herb. Lily of the valley, amazing plant for what it's so good for. Cactus, Arjuna, some herbs that have dual actions of being both tonifying as well as a little bit moving. Chinese salvia and nodo ginseng. Coleus forscoli, which is a great herb for the thyroid and affects cyclic AMP. And rhodiola rosea. So some more heart tonics. If we break them down, we've got vascular heart stimulants. Lily of the valley, foxglove, digitalis, Scotch broom, and squill. Scotch broom is really cool. It works with the electrical activity of the heart. It's nice if there's electrical issues. Scotch broom is a nice thing to add to a formula. Squill is an herb, it's one of those ones you find very little information on, but it's great for fluid in the heart. There's fluid around the heart. If for congestive heart failure, people have fluid. You can help them get rid of fluids with that plant. Peripheral stimulating tonics. These are herbs that will be work in the peripheral vasculature. The cactus, night blooming cereus, ginkgo, goticola, prickly ash, and mayapple. And mayapple is an alterative as well. So I want to talk about a few of these herbs in more detail. So hawthorn, particularly, it's been around for a long time. In Chinese medicine, it's been used, a couple thousand years. The berries were the only plant used initially, but then over time, people found out that it was really great to use the leaves, the whole aerial parts of the plant. Everything together gives the best benefit. And it's got an amazing array of flavonoids in it, polyphenols and catechins that all have this really beautiful antioxidant protective effect on the system. And I always get into this idea of quenching. The body has this constant process of developing ATP, burning fuels in the presence of oxygen, creating free radicals, and it's that process that we're always trying to quench. We're always trying to control that. So hawthorn does a really good job of doing that inside the vasculature, inside of the endothelium of our bodies. Chinese medicine uses digestion, invigorating the blood, removing blood stasis, used as a cardiac tonic in Greece. And the eclectics around the turn of the century, 1900, they thought it was the most valuable tonic herb for the heart. And that's what I think of it as. I think of it as like a medical food herb that you can give people every day for long periods of time to balance out their heart. The flavonoids, vitexin, hyperoside, rutin, organic polyphenol compounds, the catechins, epicatechin, these triterpenic acids or salic acid, these are things that sometimes I use as isolates and we'll give them along with the whole plant. Phenol carboxylic acids, these are all compounds that are going to have a profound effect on normalizing the function of the vasculature and protecting the endothelium from damage. David was talking about berries and their ability to affect antioxidant activity in the body too. It's the same principle. It's coming from this plant. And the berry is where we first saw it. If you've ever seen like berry extract that's done really well, it's so rich, it's so red and bright, and just the color is what gives it that incredible quenching quality. And it's red, so it's really good for that. You think of it as a heart tonic. Some of the effects, the research coming out of this plant is just phenomenal. I mean, there's just tons of research if you dig around. The antioxidants, the positive inotropic effect. So what is that? It improves the force and motility, the contractility of the heart. It's not like digitalis where it's really going to get the heart going to the point if you give them too much, the heart's going to go into spasm. It's just going to gently over time improve the force and action of the heart. That's why this plant is so great to use. It's wonderful. It's so safe, so friendly. Anti-inflammatory, well, we know inflammation is a huge part of the whole cardiovascular picture, and any cardiovascular disease at all is going to lead to more problems with atrial fib. So antiplatelet, another antiplatelet agent for us, vasodilating, it reduces blood pressure, endothelial protective. I just couldn't stop. I just kept digging into Hawthorne. I was like, guys, this is so much. So that's all there for you. In practice, I use it as a single agent sometimes. People who really need a lot, I can give teaspoon doses. I use a Hawthorne tincture. It's often used as the highest dosed herb in a lot of formulas for the heart. So you do a formula. I'll show you guys. I've got an example of a formula with Hawthorne in it. I can show you how I put that. And it's great with other plants, the synergy they can have with other plants. And again, super safe at high doses. And the studies show you that the longer term, more benefit. So lily of the valley, convallaria, it's another another herb that has a lot of good, antiquated historical usage among the eclectics. This is from Ellingwood. And this is one of those herbs that I use for the person who's, the older person with the weak heart. It's just great. And you put a small amount of it in a formula, maybe 10%, 15%. 10% is where I normally go. You're combining it with Hawthorne and other things, and it's going to impart strength to the heart. And it's going to actually help correct the rhyme and rhythm, improve the tone, and increase the power of the heart. There's a couple compounds, convalamarin and convallarin, which both are glucosides, cardiac glycosides, that have actions on the heart that have like a digitalis-like action, but again, more subtle. You can do it long term. It's the kind of thing you give a patient over the course of their life because their heart has been weak. And you're combining it with Hawthorne. You're combining it with other herbs. I love this herb in this context. Some of the indications for this herb, and this is why I showed you the slides about excess and deficiency, is that this is for the deficient heart. Okay? This is not for the excess heart. This is not for the 44-year-old businessman who smokes and drinks every day and is upset about his marriage. That's not this guy. This is the 85-year-old woman who has had a really wonderful life, but she's just not getting enough oxygen. She can't go up the hill. Simple cardiac arrhythmias, with or without lesions of the heart. So great for helping to normalize the activity of the heart. Look at the indications from Ellingwood. Pale, flabby mucous membranes, broad, thick tongue, heavy, dirty white coat. This person's more on the cold side. They're on the flabby side. They're on that side. The tissues just don't have tone. We want to tone the heart. So that's what this is doing. Just atrial fib in elderly folks, 80% of the cases occur in people over 65. So this is a great plant for us in this context. Cactus, a little bit different. It really increases the energy of the heart and elevates arterial tension, and it acts more on this cardiac plexus for feeble heart and valvular insufficiency. This plant is a little bit more as a nerve tonic. It's great in irregularities of the heart. But again, if the person is coming in with AFib, you want to know, you really have to understand, is their AFib caused because they're weak and deficient? Or is it caused because they're stressed out and excited? If you give them the wrong side of the spectrum, you missed it. So cactus is even, some people contraindicated in AFib. Well, that's because if you give it to the guy I was describing, it's going to make him feel more intense. It's going to intensify his sensations. Whereas that other person I was describing who has the weakness, they're going to feel better with this plant. And it really helps to get the blood out to the extremities. It helps to the heart to get the vasculature to take the blood out all the way into the periphery and make that tissue perfusion better everywhere. It's a really amazing thing. And to talk about cactus here in the deserts, it's really nice because we don't have this plant up there in Oregon. Those flowers that you saw on that last slide, These things are sought after by animals. They bloom and they have this incredible smell that people, animals can smell them from all miles around. Really a profound plant. Contraindicated in excess conditions. That's really what I want to see. I want to say about that. Poor circulation, fragile nervous system. Okay? Does that make sense to you guys? Convallaria cactus combined with hawthorn, deficient heart. Avena sativa, simple one, milky oats, right? Harvested when the oat seeds have the milk, the white milky stuff, harvested at that time. This is a nutritive. It's calming and nutritive. So again, it's not going to be sedative, but it's providing nutrition for the heart. So in folks who have that kind of fragile nervous system and they're kind of irritable and their heart's fluttering a bit and but they're pale and they're a little thin and they're a little weak, they would do really well with Avena sativa. It'll calm the heart while nourishing their system. I think Seven Songs was talking about the kinds of insomnia, the kind of people who have difficulty falling asleep when they lay down. Their mind becomes a cacophonous enclave of disconnected, swirling thoughts. Different than the pitta type of insomnia where the person goes through a litany of all the things they should have done that day or could have done better. Or for the true pitta check, telling off people in your mind. Not for those people. Nutritive. So the AFib tincture for the deficient heart, just one example. I've had great results with these kind of formulas, real similar to this for that deficient heart person. I just had a patient a couple weeks ago. He's an 82-year-old man, Tai Chi teacher, but same kind of thing, AFib. He's not on any medications or anything, but and he's this kind of guy who does not do Western medicine at all. It's hard to get him to even do a tincture, but immediately great results with him on this formula. Basically very similar to this right here. So another way we can help the vascular system is to astringe with vascular astringent tonics. I'm not going to hit these too hard. I'm going to work on them tomorrow as well in my prostate talks. But these are all herbs that help to astringe the vasculature. They help to increase vascular tone. And that's a really good thing with the deficiency picture. And these are people that have a lot of the spider veins. Here you can see the ankles start to pool, hemorrhoids start to pool. Pooling of blood in different areas, we want to help them strengthen those blood vessels, strengthen up those backflow valves, get the stenosis out of their blood vessels. Motherwort, we've talked a lot about that at this conference already. Very calming. In Chinese medicine, it moves the blood. It's also kind of like, I think David was calling it a nervine, or you called it anxiolytic, right? Oh, I do, don't I? This is Leonoris, guys. Sorry, thanks for catching that. This should be Leonoris. The funny thing is these two plants, motherwort and Lycopus bugleweed, are used together to calm the thyroid, but that is a really good mistake to catch there. Leonoris, guys. Cardiaca, thank you. So, but Lycopus could be in this class too, but I use that one really more specifically with thyroid stuff, hyperthyroid. In Chinese medicine, it's used also with hormonal headaches. Monjingsa, for what we call a wind-cold invasion, also has some kind of hormonal effects, but it's very calming to the heart and very good for moving blood, for stagnant blood conditions. Here's another herb for blood moving, Salvia miltiorhizome. This herb is one of my all-time favorites. Removes stasis in the mansion of blood. It's a classical formula for blood stagnation, but salvia also is a little bit tonifying to the heart. It has a little bit of a tonic activity as well as clearing heat and moving blood. So it can kind of go on both sides. If the person has any signs of blood stagnation, any cyanosis, any purple, any pain, chest pain type of stuff, then this is a great herb to add in their formula. This is the ingredients for that formula. I'm just going to leave that up for you. It's on the slides. Tons of research on salvia as a heart-regulating plant. Lowers C-reactive protein, lowers homocysteine, protects the liver and heart. And again, with angina, with palpitations, with the heart pain, this is a great plant to have in there. And I put that in my tincture for excess conditions. So hawthorn, salvia, white peony, ziziphus, bupleurum, and rowolfia. It's a plant that we can still get and still use, which had a compound extracted from it called reserpine, which was used as an antipsychotic, which is very calming to the central nervous system and actually starts to help get rid of catecholamines in the nerve endings, which is really great because it just calms the really restless heart And it's great for people. For hypertension, I find it to be a wonderful plant. I almost always drop dose it with people and find just the right dose. And it's a really wonderful plant. It's one of those plants, if you use it in the pale, like overweight, thyroid deficient person, and you give them a bunch of Wolfia, they're going to feel terrible. It's got to be in the person, again, who has the excess condition, okay? Here's some nutrients. All of these are super important. Somebody hit on it early, magnesium deficiency, right? Proton pump inhibitors, they block our uptake of nutrients. The Framingham heart study did a second run where they did the Framingham offspring study. They took about 5,000 offsprings from that study who came in, who was started in 1936, then it was 1972. They followed them all, and when you find that magnesium in the body, when people have higher levels of magnesium, their AFib levels are almost nothing. People who were in the upper quadrant had 50% less AFib than the people who were in the lower quadrant. So magnesium deficiency is coming from all kinds of places. It's the pesticides we're using now that are draining and depleting our soils. It's the soil conditioners and foods we're using that are not rich in magnesium. It's the grain storage that we're using too, and this processing of the grains that's depleting magnesium. So our foods don't have magnesium anymore, and we need magnesium. I just think of it as I give everyone magnesium. Pretty much every patient who comes to my door almost going to get magnesium unless they're already taking it. Let's talk about a few forms. Taurate, glycinate, aspartate, citrate, oxide, carbonate, and lactate. For the heart stuff, AFib, my favorite form is taurate. It's a little more bowel stimulating, so you still have to watch that, but dosing-wise would still be in the range somewhere between 500 and 1,500 milligrams a day. Magnesium taurate for the heart, and tauric acid, of course, is the acid form of taurine, and taurine is going to be very calming to the heart, very supportive to the kidneys. Taurine lowers the blood pressure, and you can dose taurine really high, anywhere between 1 and 6 grams a day I go. Some people, I just say, just keep going up until you feel your heart calm down, and it works wonders. Taurine, and it's very safe. It's nothing like what you see in the energy drinks, taurine for your energy drink. I don't know what that's all about, but taurine itself is a wonderful compound. Glycinate I use for people who have bowel problems. If you're having bowel troubles with magnesium, you can't get your magnesium levels up, glycinate's the best form. It's the most safe to use without stimulating the bowels. And the only problem you're going to have with magnesium toxicity is just they're going to have diarrhea. So it's great for the constipation in these people. Just give them more magnesium and they'll get going. But as you build the dose, the key thing with magnesium is you build the dose slowly. And as soon as they feel a change in their bowels, back it off a little bit. And that's how I always dose it, with whatever form I'm using. Citrate is fine. People get it at the store all the time. It's not the most absorbable form, but it's more absorbable than carbonate. It's going to be a very bowel-stimulating form, citrate. It's going to move the bowels real good. And carbonate is really good. If you combine it with some things, it can calm the stomach down, but it doesn't really a lot of it doesn't get into the body as much. It's going to work more going through the digestive tract and having an effect there.
What about malate?
Magnesium malate, I didn't put up there because I use it pretty much for, it could be good to put up, really, it should be in here. I threw this slide in kind of last minute. Because it does do a good part of malic acid is part of the citric acid cycle, part of the Krebs cycle. It's more fibromyalgic type stuff, mitochondrial deficiencies. I definitely like it a lot for that. And malate's also bowel stimulating, so you've got to watch your dosing on that one. I know I'm running out of time here, guys, so just going to get through the last couple here. Potassium. One thing about potassium and magnesium is that they work together. Thanks, David. Potassium and magnesium together, they affect each other. So oftentimes you'll need to get people on one or the other if the one you give them doesn't work. Magnesium will regulate potassium in the heart. That's a really good thing. But sometimes we've got to give people some potassium. And I like to use potassium, magnesium, taurate, both of them together, 200 to 600 milligrams a day. But a lot of times people will still need more magnesium. The magnesium dose will be higher than the potassium dose. I found that a lot of people do need potassium. It just depends. One of the things I find too with it is that if people get sweaty palms and feet, that thing, potassium, magnesium, taurate. It's my favorite things for that. Coenzyme Q10. God, this is just an incredible compound. Sorry, guys. I'm sorry I didn't get through it all. People who are leaving. Sorry. Missed you guys. CoQ10, it's ubiquinol and ubiquinol. It's just phenomenal. ATP supports the muscles throughout the body. It's also similar to vitamin K in some ways, so there is a concern with interfering with warfarin, with this substance. I haven't seen it, but I would be aware of it. It has a vitamin K-like effect. And I want to talk about vitamin K because vitamin K2 MK7 and MK4, both of those forms of vitamin K2 will help to take calcium out of the blood vessels and put it on the bones. And the Japanese studies on osteoporosis and osteopenia show that the dosing they're using is 45 milligrams of vitamin K2 per day to inhibit osteoporosis and reverse it. So most of the time, the RDA right now is 150 micrograms per day. So we're talking about a lot more, but I've done it with a lot of people over many years, and it's great. I've never seen a problem with vitamin K2 dosing outside of warfarin. And great to pull the calcium out of the blood vessels. Vitamin K, it's the stuff that does it. Out of the blood vessels, onto the bone. Great study on rats where they actually got them to have huge amounts of atherosclerosis, calcification, gave those rats vitamin K, and their arteries softened. L-carnitine, the carnitine shuttle, it's really all about moving fatty acids through the mitochondrial membranes. So it just enhances energy flow and flux and improves the energetic way that the myocardium is going to function. We talked about taurine, stabilizing membranes, 1 to 6 grams per day, 1 to 2 grams per day of L-carnitine. The N-acetyl form, more for neurological stuff. The L-carnitine, great for the heart. These are just, fish oil. Interesting enough, there was a study on fish itself. Eating more fish didn't actually improve outcomes, but taking high doses of EPA and DHA did. Modulating prostaglandins, inhibiting arachidonic acid, downregulating inflammation, softening the vessels. That's what the fish oils do. Dosing is right there for you. Nutrition. I talked about the stenosis and vitamin K. When those valves are stenosed, vitamin K is the stuff. When there's a problem with the valve regurg, it's normally because the heart muscle got misshaped, often because the blood vessels were hard and the left ventricle started pumping too hard and it got really muscly. And then guess what? The valve doesn't quite fit because the muscle's not sitting right and the valve's slightly off. So what do? You give them CoQ10, you give them hawthorn, you give them carnitine, you give them B12. And you bring that stuff together, you get their muscle working again, the body takes away hypertrophy. It's there for a reason. And it'll go away. We can remodel this stuff with the right nutrition. So what do we do to treat AFib? First thing, address the clotting risk. It's important. Stabilize the heart. We can do that with the plants that we just talked about, but make sure you know which way you're going, excess or deficient. Identify the underlying causes. Get them on formulas. Get them on nutrition and plant formulas to start to harmonize their body. Get their lifestyle factors figured out, and then treat the whole person. And that's it.